Good afternoon and welcome to the 11th plenary of our Congress. And the topic is considerations in setting up a robotic surgical services. And the speaker will be Professor Rowan Parks, who doesn't need any kind of new introduction, because he was amply introduced when the college awarded him with the honorary fellowship. And he has been a friend for last decade, one decade, and professionally very close to us. And this was a kind of a dream topic for all of us. We were so close to this just before the pandemic broke in. And we were working on that, so I'm sure Professor Parks will throw some light on this subject. Let me invite him to share his wisdom with us. Over to you, Rowan.
Well, thank you very much. And it is indeed a huge honour to not only be here in Sri Lanka, but now to be a fellow of your college. It's a phenomenal honour. So I have two things in terms of introduction to say. Firstly, I'm not a robotic surgeon. I have never done a robotic operation. And secondly, I'm very aware that here in Sri Lanka, you do not yet have a robotic service. And that's exactly the position we were in Scotland about 18 months ago. Certainly in our government public hospitals, we didn't have robots. There were, in other parts of the UK, certainly in England, a lot of robotic services up and running. There were some privately funded robots in some of the institutions in Scotland, money raised by philanthropic means or by charities. And so there was some robotic surgery being done, but not funded by the government. Until about 18 months ago, when all of a sudden 12 robots appeared across Scotland and were funded. If that had been now, 18 months later, I don't think Scottish Government would have funded those, because, similar to yourselves, we are seeing the highest rates of inflation, of taxes, and of financial squeeze that we've seen in 40 years. So I think we had a window, and that window opened an opportunity. And the reason I got involved in this is because of my immediate past president, Professor Mike Griffin, said, as a college, we need to think about this. And Rowan, would you take this on? So this is the story of what we did as a college. And as a college, we thought it was really important for a number of reasons. As a college, we're involved in education, in assessment, in accreditation, and in standards. And that has formed the essence of why we thought it was important as a college to get involved. And I suspect a lot of parallels could be drawn with the College of Surgeons in Sri Lanka. You're involved in education, in accreditation, in assessment, and in standards. So one of the things we did was set up a task force. And in the UK, we have 10 recognised surgical specialties. So we put this task force together with a representative from each of those 10 specialties, some of whom had done quite a bit of robotic surgery, particularly the urologists, who have featured heavily during this conference. But some of the specialties had done absolutely no robotic surgery, but they were starting to think about it. We knew that simulation would play an important part in education and training, so we have a lead within the college for simulation. We recognize very much that, as well as the technical aspects of any new innovation, as a college, we're very focused on the non-technical skills that are needed. So we have a lead for NOTS, or non-technical surgical skills. We have clinicians who lead for education, and our convener and deputy convener of education were on the task force, as well as the administrative staff from the education department. And one of our trainees who had a big interest in robotic surgery. So that was the essence of the task force and the team that we put together. And at our very first meeting, when we convened it, we had a blank sheet of paper. And we said, what are our key objectives? What do we need to produce? And the first thing that came up were standards, a document that would provide some guidance around standards. And as a college, we felt that was important. And we produced this in about 3 months. And I'm going to refer to this document. We also felt training was really important. And we thought about how to stage that with an introductory course and essentials and what robots could do. We also felt it was important for those who would assist the surgical first assistants, and we needed to develop some courses for them, as well as the very specific specialty and procedure-specific courses that would be required. So education, training, and courses was the next area to consider. We felt we had to learn from world experts, and so we set up a webinar series that started a few months ago. It's running every fortnight for about 6 months and is utilizing technology and webinars to hear from experts from all over the world, from Asia, from the Americas, from Europe, and we have coordinated those webinar series, which you can all get access. I'll mention some of them later. We also felt it was important to see if we could get some funding, particularly for senior trainees or for consultants, to go away and learn in centers of excellence, and we want to develop robotic fellowships. We wanted to build some research around this, and those were our key components. I'm going to come back to this guidance document because this we felt was the priority. Lots of centers across the UK were wanting to start up and establish robotic services. How do you go about it? What do you do? And this is the document we produced. This is available on the college website. You don't need to be a member or a fellow. You can just go and go onto the Royal College of Surgeons of Edinburgh website and download this document. We felt it needed to be practical. It needed to focus on training and clinical governance. And it was essentially to provide a toolkit highlighting good practice and good standards of care. And the emphasis was on it's not just for the surgeon, but in the entire surgical team, the multidisciplinary robotic surgical team, to ensure that what is being introduced is done safely and is got the patient at the heart of it. So that was the reason, that was the priorities and the efforts that were put together. It's a relatively short, easy-to-read document, about 20 pages. You'll not be able to read all the contents, but it includes how to set up the governance for a robotic service, what to think about in terms of the training, how do you embark on your very first few clinical cases when you actually start using the robot, and then how do you monitor, firstly, how do you consent patients, having a new technology, a new innovative way of doing things, how do you assess that the surgeon is able to operate independently, the whole idea of proctorship, and then how do you maintain good practice and audit outcomes. These are the sort of areas that were considered. Now, if we go back to the key pillars, we felt it was really important to ensure when setting up a new service, a brand new service using new technology, that there must be good clinical governance. So we recommended that there should be a robotic governance and peer review group, a governance group, and then an operational group. And each institution, each hospital, each health board, in the UK, what we call trusts, but basically each institution should consider this and have a governance group. That governance group, as highlighted on the left side of your screen, would consider issues such as education and training, who would get surgical privileges, which specialties should be allowed to develop the service, how do you protect patients, how do you audit outcomes and the cost effectiveness, how do you approve proctors, where they come from. A lot of them are outside the UK, so how do you approve such individuals, how do you share good practice, and how do you actually build a business case for developing these new services. So that was a governance group, and I'll come back to that. Also an operational group. Bringing in this type of technology requires a lot more than the surgical team. It needs IT input, medical physics, clinical engineering in the theatre environment, the whole aspect of the sterile services, stores, procurement. So it needs that operational group to consider this technology. The governance group, if you have established robotic surgeons, and in the UK that tended to be the urologists, they should be part of that group with any new adopters. And in the UK context, yes, there's a little bit in thoracic surgery, a little bit in head and neck, but abdominal surgery, GI surgery, particular lower GI, they were the ones itching to get going in this area. And we had a fantastic seminar yesterday, hearing experiences from India of colorectal robotic surgery. So these new adopters, as well as the anaesthetic staff, the surgical care practitioners, and other members of the operating theatre team, the nursing staff, ODPs, as well as hospital management. These needed to be the key groups involved in that governance group to oversee the introduction of a new service. So that's clinical governance. What about training? What are the aspects of training? Some of these were covered very eloquently yesterday. What are the components of robotic-assisted training? Well, it involves some online learning, and a lot of the providers, a lot of the companies provide very good material. It is all there. A lot of it is modular and self-directed, but it can be done online, the theoretical basis behind using a robot. Following that sort of online e-learning, you can move into familiarizing yourself with the particular vendor and equipment. So the familiarization of the robotic system before moving on to simulation on that device or robot. And when you're doing that, there's the individual surgeon, what he needs to learn, as well as the wider team, and thinking about the non-technical aspects of communication. When you're using and set up in theatre in a very different way than normal, how do you communicate between the different parts of the team? So it's thinking about things like that. And then moving on, bringing that team together and working through practical cases, and then introducing a robotic program with proctor guidance. So that's the components, the stages of robotic training. When you embark on those early cases, the initial cases, your first few cases, pick simple cases, pick straightforward cases, not complex, hopefully not obese patients, but patients that technically should be more straightforward. And start with straightforward procedures rather than going straight to a very complex surgical procedure. But you gradually then can evolve as things progress. But throughout, you must always continuously assess the outcomes. Continuous quality improvement is part of introduction of any new surgical service. And when you're using new technology, that's really important. So assessing the outcomes and also the cost implications. And that was very eloquently covered yesterday as well. So this can be mapped to the whole surgical team, not just the individual surgeon, but the surgical trainees, the assistants, surgical care practitioners, the theatre staff, theatre nurses, anaesthetists, and the various components that they need to do are all on a tabular form, which again is easier perhaps when you download the version from online. So that's clinical governance, that's introduction of a new technology, it's some thoughts around training. But we wanted as a college also to start familiarising our trainees with the procedure and set up and funded a very basic introductory course for all our surgical trainees in Scotland. So we were able to get some funding that every single core basic surgical trainee came to the college. We have 2 robots in the college funded by industry, and they can come and actually get a day course, how to use, how to dock, how to undock the various arms of the robot. We call it a very basic introduction, essentials It's not going to teach them how to do a procedure, but it's a familiarization. And the new generation, the young generation of surgeons are desperately keen, and I'm sure in their lifetime all of them will be, or at least the majority will be using robots. I think there will be a place for it. So how do we introduce and start the first number of cases? And I think this is quite important from a clinical governance point of view. And so we have suggested there's a structured clinical pathway that starts with preceptorship. That's where you go and observe the robot being used. So as a surgeon, if you're keen to get involved, it's a very good thing to go and watch others do it. That might mean getting a fellowship, a scholarship, and going and spending some time in another institution. It may mean traveling overseas, but to go and see it used in action is worthwhile. You then need to, with your own team, work out what the operating procedures, the SOP, the standard operation procedures would be, as well as what you would do in an emergency. If you got bleeding, how do you very quickly convert? And you need to think of the steps before you even start any cases, what you need to do. Then there's a whole concept of proctorship. That's where you have someone who is very experienced come to your institution and do the first number of cases with you, observing, guiding, helping, and giving proctorship. That's what that is all about, before you move into autonomous and independent practice. But as you're doing that, auditing the outcomes and maintaining your skills. And that might mean, if you're only doing occasional cases in between those, doing it on a simulator and getting access to a simulator. What about consenting patients? How do you consent a patient for a procedure that you've never done before, that might never have been done in your institution or even in your country before? What are the principles to think about when you're explaining that and getting informed consent? Again, this is something our college is very interested in and has done a lot of background evidence gathering, and has now a number of courses around consenting and communicating with patients. And patients do need to be counselled appropriately. And the surgeon needs to take ownership. This isn't something to pass on to a junior member of staff. The surgeon who's going to be leading this needs to undertake the consent procedure. All the information about what it involves needs to be delivered, whether that's verbally, written, online. And you need to explore and get the patient's understanding of being one of the first, if not the first, to have this new innovative technology used on them. I think it's really important that there's full disclosure, that you do explain this is at the start of a learning curve, because undoubtedly there is a learning curve. You need to explain that the team mightn't have done many of these before, and there might be a need to convert to an open or a conventional procedure. And so the benefits and risks need to be talked through with the patient. And then the explanation of what a proctor is, what they will be doing if they're going to be present. So there needs to be shared decision-making and good documentation of that. So I've very quickly run through a lot of the concepts behind the standards, or the guidance as we've called it, for developing a new robotic surgical service. It's downloadable from our college website, and I'm sure you should be able to find that. If not, we can certainly point you. And you don't need to be a fellow or a member. It's open for everybody. We've actually circulated the document to every single chief executive and medical director in the UK, and it's been very well received in terms of a very helpful document. As well as that, I mentioned our webinars. We started these a number of months ago. They're literally every fortnight. With the time difference, you can, if you wish, tune into them if the time suits, but they're also available from our website, the back catalogue. And it covers thoracic surgery, esophagogastric surgery, you can see here, a bit of gynecology surgery as well, training and outcomes. Those are just a few that were run over the summer months, but they're still ongoing, and we have a program that will take us into early 2023 on webinars. So in summary, if you are thinking of setting up or establishing a robotic service at some point in the future here in Sri Lanka, do think about the governance of that in your institution, and also a team to look at the operational aspects. consider what a structured training program might look like. And again, I suggest the college here in Sri Lanka might be minded to consider developing some of those modules and what that training would look like at an individual level for the surgeon, but also for the surgical team, and consider the non-technical aspects of that as well as the technical aspects. Start with simple cases before graduating on to more complex cases. You can start even now thinking about proctoring, and certainly there's a lot of surgeons in Asia doing robotic surgery, so getting access to them might be appropriate. Do think through how you consent patients and what the consent will look like, and then, as always, good practice is to audit what you're doing, what the outcomes are, and continuously learning from that. So thank you again for this opportunity, and I look forward in the coming years to hear how things develop here in Sri Lanka. Thank you very much.
Thank you very much, Professor Parks, for that enlightening talk. And exactly 12 years ago, I was told by one of my trainers that one day you should bring a robot to Sri Lanka. So we are working on that. And if you can remember, last year we were debating whether we should train young surgeons on open cholecystectomy because laparoscopy is taking over. And today we are talking about robot. And I'm sure by next year or in 2 years' time, we will see some papers publishing by our young surgeons about robotic surgery in Sri Lanka. So thank you very much for that enlightening talk. And on behalf of the college and the council, let's thank with applause. Thank you so much, Professor Parks. There's one announcement, I think there'll be at 1:30 council room, there's surgical literate discussion at 1:30. Is that correct, Gayan?
Yes. We have the privilege of Dr. Carmel Miranda, who has won the Gratian Award and one of the few doctors who have done so, getting an award. So please do join us for the lunch literary corner, and it will be something useful. Yeah.
Thank you. So we'll conclude this session. Thank you very much.